Well, hello and welcome to the COVID-19 and Hematologic Malignancies Expert Insight webcast. This is now our fifth episode of actually seven. We've extended our program now to have seven different programs within the overarching program. And today we have the privilege of being in our fifth episode, where I will shortly interview Yelak Biru, who is a patient advocate and a member of the board of the International Myeloma Foundation. My name is Dr. Joseph McHale. I'm a hematologist. I'm a professor at the Translational Genomics Research Institute and the Chief Medical Officer of the International Myeloma Foundation. We're very thankful to be able to bring you this series and trust that it will be helpful to you as we try to incorporate all the new changes in life that COVID has brought us into our heme malignancies practice. We're also very proud to offer this as a CME certified program. So you'll see as you watch this that there are opportunities to submit feedback and to, at the end of the program, be able to request your CME certification. We have questions for you that we hope will help you and give you deeper insight into what we are seeking to provide you today. Well, as we've mentioned, today is a very special part of this series where we have the privilege of speaking to a patient advocate who himself is a myeloma patient and also a very good friend of mine and just an absolutely wonderful human being. So it's a joy for me to be able to share this video today with Yelak Biru. So Yelak, it's so nice to see you, my friend, and thank you for joining us.
Thank you for having me, Dr. Joe. After that kind of introductions, I should just be quiet and say nothing.
Oh, no, absolutely not.
Interact for a few minutes.
No, we're very thankful to have you here, and I look forward to hearing my voice less and hearing your voice more as we talk through. So over the next 10 to 12 minutes, I'd like to get some of your insight into really what this COVID crisis has meant for the cancer patient. And maybe for our first part here, let me ask you, how has the cancer patient community in general been dealing with this? I know that there's a tremendous amount of fear and it can be very isolating for all of us, perhaps even more so in the cancer community, but share with me your thoughts around that and how we've been able to overcome at least some of that.
Sure. We have dealt with cancer patients for many years. And when cancer patients are first told that you have cancer, the first thing that comes to their mind is, how long do I have to live? And that is coupled with the fear and also sense of losing control of their life. And when you then couple that with COVID, and what COVID brings to the table is compound that uncertainty with the uncertainty of, do I get COVID? If I get COVID, will I be able to survive? Or because I have a hem malignancy, would I not be able to survive COVID? And while living with myeloma, I may not live with COVID, right? So that fear is real and in some cases could be crippling. I have friends that are on social media that I interact with that have been homebound for over 3 months now and are afraid to leave their homes. And so this concept of social isolation or physical distancing from others is real and actually leads to not only that isolation, but associated depression and other mental problems that as advocates and as you physicians need to make sure that is not ignored.
Yeah, that's incredibly insightful. Thank you. Yeah, like I know for every one of us in some respect, even as myself working in the front lines and being in the hospital and the clinic on such a regular basis, this is still very isolating. And I imagine it just amplifies that within the patient community. So if you are speaking, which you are indeed, to primarily a physician and healthcare provider audience, although I know that there'll be some patients listening in too, especially when they know you're here, what sorts of things can we as providers do to help with that fear, to help with that isolation, to minimize that? I mean, thankfully, in many respects, the COVID crisis seems to be descending, but it's still going to be with us for a while.
Yeah, you guys, physicians and researchers, are really good at measuring physical response to treatment and response to overall care. Mental challenges or mental issues, including depression, as a result of this COVID, even with myeloma, are in some cases not discussed because the physicians are not always comfortable with that. So this is where I tell myeloma patients that they need a team approach, right? They need to have a team of people that are helping them in their care. So the same as somebody has a myeloma expert, an infectious disease expert, if they have to deal with COVID, it really is also important to have a mental health expert as part of their care team. While I understand that physicians may not always be in a position to be able to help patients in that way, patients need to take proactive role in order to be able to build this multi-discipline care team, which is also what I think physicians and clinics need to be able to ensure they also have that multidiscipline care team.
And that's a really good point, because, I've long advocated, obviously, the importance of the physician-patient or the healthcare provider-patient relationship. I mean, it really is at the center of what we do in medicine. And I think COVID is helping us see the absolute importance of that although in many respects it is ideal to be able to sit at the same table with the patient or in the same room, that it's incumbent on us as providers during this time to address the elephant in the room. And even I know that in many of my patient discussions virtually, because we do so many of our patient visits now virtually, even though their myeloma measures are completely benign and everything is stable and their response to chemotherapy is excellent, there is that mental health concern that you've described, that fear, that isolation. I think maybe one silver lining of some of the virtual approaches is that sometimes I get to see patients with their spouse and their pet next to them, and it gives us a human dimension that we have to look at. And I really think for those listening in today as providers, your responsibility is not just to the patient's tumor, it's to the whole of them. But from your perspective, Yelak, have you been hearing about positives and negatives around these virtual visits? I mean, has this been in some ways a good thing? Like, I know in my clinic, I'm actually seeing more patients than I would have otherwise seen who can't travel to see me. I get to see them by virtual means, but I miss that human contact dimension, that the real closeness that you can obtain face to face. What perspective have the patients brought?
The good thing about virtual visits is I can visit you, one of the myeloma experts, from anywhere in the country or even in the world, right? So that is really the side benefits of virtual visits. The challenges with virtual visits is it's not always easy to read body languages. I may have mentioned that I actually changed my previous treatment because of the body language of my myeloma expert, because I was in front of him when we were discussing treatment. And while he was verbally telling me it's okay to get on that treatment, I can't tell from his body language, don't do it. So that was really important for me to be able to make that decision. So even I think the reverse is true for you. You may not be able to read if I am in front of you over a screen that I'm actually not as smiling or not as talkative as I am normally, or be able to assess how I'm doing from that nonverbal communication perspective. Because you are in most cases seeing this. In other cases, you are distracted by my dog, as you mentioned earlier, or the issues with technology is I don't know how to use it as a patient. And actually, in some cases, you may be seeing the roof of the room or whatever, right? So that technical barrier, technology barrier is there. Also, in the underserved community, not everybody is able to leverage uh, internet or have internet or smartphones in order to be able to participate in that virtual care, which I think is important for physicians and clinics to take that into consideration and allow for an exception, if you would, for to that virtual visit.
I think that that last point you've made, yeah, like particularly resonates with me, and I think that's very important. You know, we've had some visits with patients that live in very rural areas, or and you know, in our world of multiple myeloma, we know we have many older patients who may not have the technical expertise that you've described. I had a virtual visit the other day where they could get the video working, but not the audio. So they had their computer on and their phones at the same time, and we made it work. But you know, and I make light of it a little bit, but I think it really is an important issue, because some have advocated that, you know, basically we can almost always go to virtual patient visits, almost like we want to go to virtual meetings. You know, virtual is becoming a tough word for me, and I do think we can't lose that human dimension. I was on a video consult with a patient the other day, and I wish they had tilted the camera down a little more, because I think I saw the patient reaching over and trying to quiet down her husband because he kept interrupting. If we were in a real room together, I would have seen them doing that. And I
Yeah.
think we do lose that. You know, I think for the short term and in certain visits, it's helpful, but not just for the physical exam, but for all of those reasons you described. That's really helpful to me. You know, yeah, like the other question I wanted to ask you that I know you feel very passionate about, when we had our roundtable discussion, we had this really, I thought, beautiful discussion around balancing reality and hope. And one of the things that I've been very, very passionate about through this whole series that we've been doing on COVID has been the notion that we can't throw out the baby with the bathwater, as it were, meaning we can't be so COVID focused that we lose sight of the fact that patients have real disease that really needs to be addressed in multiple levels. And tell me a little bit about your perspective through this, because I know you've instructed hundreds and thousands of people over the years around the importance of advocating for themselves and for the kind of approach that is so necessary in cancer. And how does one balance that with all that's going on with COVID?
Yeah. So as you may know, I led the North Texas Myeloma Support Group for many years before moving into the Northwest Arkansas area. And the mission of the North Texas Myeloma Support Group is to create and share hope with myeloma patients, caregivers, family, and friends through education, support, and our personal experiences. So in order to be able to create that balance between hope and reality, it really is important to take the whole patient ecosystem, the patient, the caregiver, and the family, but also take into the equation the education that we need to provide to the patient, the support that we need to provide to the patient, and the ability and the importance of patients sharing their personal experiences with each other, because that in itself brings hope. While it does not replace, clinical trials or validated outcomes, patients really have a powerful relationship with other patients that are traveling that journey with them. And so being able to share their personal experiences is important. But COVID is hopefully for a myeloma patient that is going to live for the next decade or plus, thanks to all the research you guys have done, hopefully is like a side challenge that we have to overcome, and we have to remain alive through that in order to take advantage of all the drugs that have been approved for myeloma, and also all of the drugs that would soon be approved through the clinical trials. So I think it's really important to mention what we should do as myeloma patients to continue to live longer with myeloma. To me, having a myeloma specialist is paramount, especially if you are at an area of you have the means to get one. As more and more drugs become available, the equation of what should be my next treatment is becoming more and more complex. And nobody can help you navigate as well as a myeloma specialist can. And we talked about the need for building a team, whether you are dealing with COVID or with myeloma, because you are one of a kind, but also as a human being and as an quote unquote an elderly person, you have other things that you need to deal with. I need to deal with now that I have lived with myeloma for 25 years. So I need to make sure that I build that team of specialists to continue to help me through my myeloma journey.
That's very insightful, very helpful. Yeah, like, I mean, you're an inspiration to so many of us and how you've handled it, and, you know, leading support groups and helping innumerable other ones. I've been hearing about how many of the support groups are meeting, ironically, even more regularly, although virtually. And I think one of the things I'm hearing from my patients too is that you kind of got to find what works for you. Some people really benefit from a certain kind of model of support group. Others approach it a different way. And I really try to think of every patient. I say to them, you know, you're individual, just as you have an individual appetite for your meals, you have an individual desire for your knowledge of your disease, and being empowered through that and building that team around you. I think we are in an unprecedented time in medicine of team approach. We've given it lip service and some genuine approach for many years, but I think now more than ever that team concept is important. Well, our time is almost done, but before we go, I want to give you another opportunity to leave us with some concluding thoughts. You know, although this whole series that we've been privileged to do with IMEDX has focused on the COVID crisis and many of the immediate strategies that we're taking to deal with this, but we also want to look at the long-term strategies. And many of our patients that we're treating with heme malignancies for good reason have become chronic malignancies, chronic lymphocytic leukemia, multiple myeloma, certain forms of lymphoma are really ones in which the patient is going to have this disease for many years. What thoughts can you leave with us to help both the patients understand and the providers understand that long-term focus and how important that is?
I'm going to pivot this a little bit because COVID has affected African Americans disproportionately, and has highlighted the overall disparities in care for not only myeloma patients, but also anybody that is being impacted by COVID. So in my opinion, it really is not enough for healthcare institutions, whether they are industry or government or research institutions, to stand against health disparities and clinical trial underrepresentations, which leads to drugs to be approved. I think the test of the day today is whether those institutions will use their power to fight this inequality consciously and over time.
No, that's brilliantly put and so pertinent this week and every week, frankly. I mean, as you have been such a partner to me, I appreciate that as we've launched a very large African American initiative, with myeloma, and I'm sure our providers listening know this, that multiple myeloma has twice the incidence in the African American community than we see in the Caucasian community. And in some ways, that's shared with COVID in the sense that we've seen disproportionately more African American patients and patients of various backgrounds. I work in Arizona, and we've had a significant outbreak in the Navajo Nation, and it's been a tremendous challenge. And we've been working with leaders there and with others to try and facilitate ways to care for patients. And it's sad in one way that COVID has had to further highlight that to us. But if you're listening today and you're a healthcare provider, I mean, again, as I always say, I don't treat myeloma, I treat people. And we have to look at them as people and understand their unique situation and background and be advocates personally. And I think you said it so well, Yelak, that even our institutions have to be much more influential in the field than just saying, oh, yes, we should increase enrollment in clinical trials and certain access to therapies. I get that. But there's so much more to this. Well, thanks, Yelak. It's always such a pleasure to talk to you. And I really hope that those who are listening in will be inspired, as I've been inspired by your story, and also by the help that and the intelligent insight you give us in these issues. We trust that you'll continue to join us for our final two sessions. We still have episode number 6, where I'll have the chance to speak to Jessica Altman and speak to her about how the COVID crisis has impacted the care of patients with myeloid diseases, such as acute leukemia and myelodysplastic syndromes. And then we are going to have a bonus, if you will, 7th episode that we didn't initially plan, but there's been so much interest and so much discussion with our colleagues from infectious diseases that we're going to have Dr. Michael Satlin come back and join us, who is an infectious disease specialist in New York City, and share with us further insights into the care of patients with this awful virus. But thank you again for joining us. You can absolutely obtain your CME credit by following the instructions on your screen, and also provide questions to us. We've been having many questions come in, and we seek to answer them in the best way that we can. So if you have questions, please do chime in and provide them to us. We look forward to seeing you in our next episode. Again, lastly, thanks again, Yelak, for joining me. It's a pleasure to have you, and we trust all of you have enjoyed the program today. Thank you.